Epi actually showed no survival benefit. All right, you guys, as promised, I dug into the Epi data a little bit more. I looked at a 2023 network meta-analysis that analyzed 18 randomized controlled trials and looked at over 21,000 patients. They tried to answer, does Epi actually save lives? So Epi does work for those immediate outcomes. They saw an increase in ROSC, an increase in survival to hospital admission, but when they really looked at things that really matter, like clinical outcomes such as survival to discharge and good neurologic outcomes, Epi showed no significant benefit compared to placebo. So compared to giving nothing. So the drug that we give in every code, we may get pulses back, but it doesn't really leave patients neurologically intact. Sounds crazy, right? So here's where it gets critical. The researchers separated patients by initial rhythm. So non-shockable, so our PEA and asystole, versus shockable. So in the non-shockable group, Epi actually doubled survival to discharge and had a clear benefit. Shockable rhythm, so VFib, pulseless V-tach, Epi actually showed no survival benefit and actually potentially a trend towards harm. So what about high-dose epinephrine? So the meta-analysis compared standard 1 milligram doses and high-dose epinephrine. So result, all increased ROSC and hospital admission, but none improved survival to discharge or neurologic outcomes. So more epinephrine does not equal better outcomes. So what should you change in resuscitations? For shockable rhythms, prioritize your CPR, prioritize defibrillation, minimize your interruptions, and then potentially give epinephrine, but I would not give this before defibrillating for sure, and potentially delaying it even a little more if you are, if there's other interventions that might be more helpful, like CPR and shocking. So for non-shockable rhythms, Epi does show a clear survival benefit. Give early, just as the guidelines recommend, understanding that one size does not fit all in cardiac arrest. So bottom line here, we had a big meta-analysis with 18 trials, over 21,000 patients. The evidence is clear. Epinephrine gets ROSC, but it may not save lives in your shockable rhythms. So we need to rethink our reflexive approach to Epi and VFib and V-tach arrests. The best drug for shockable rhythms, electricity.